So osteoporosis is a common condition, affects approximately 1 in 2 women and 1 in 4 men over the age of 60. Today we have very effective treatments for osteoporosis. In Australia we're very fortunate that most of these are covered on the PBS. As first-line treatment for individuals with osteoporosis, we have oral and parenteral, that is intravenous or subcutaneous treatments. Treatments in Australia are covered by the PBS and can be prescribed for individuals who suffer minimal trauma fractures or for individuals aged over 70 years of age with a low BMD T-score of less than -2.5. Other treatments for osteoporosis are also covered by PBS if individuals, for example, have low bone density and have conditions where they need long-term corticosteroid therapy. So the options that are available, the first-line drugs that are available, are either the bisphosphonates or denosumab. The bisphosphonates can be given orally or intravenously, whereas denosumab is given subcutaneously. The fracture efficacy of both drugs have been proven adequately in large randomized controlled trials. Spinal fractures are reduced by approximately 60 to 70% in individuals who are given either subcutaneous denosumab or IVs of hyaluronic acid, and by approximately 40 to 50% in those receiving oral bisphosphonates. Hip fractures are reduced by approximately 20 to 40% using both oral and parenteral therapies. While these therapies are very effective for the treatment of osteoporosis, they do have potential side effects. If we look at the different side effects, they often influence what agent the patient prefers or what agent the general practitioner prescribes. The intravenous and subcutaneous preparations aid in patient adherence and compliance because they only have to be given either annually or every 6 monthly and can be improved by patient recall methods. And they eliminate the side effects of oral drugs, which are mainly the gastrointestinal side effects which are seen with the oral bisphosphonates. One of the major problems, which is very, very rare but raises its head and really influences the long-term persistent and adherence of these medications, is the entity of osteonecrosis of the jaw and atypical femoral fractures. The latter are fractures which occur in the diaphysis or shaft of the femur and occur spontaneously in individuals who have been on long-term anti-osteoporotic therapies. These are exceptionally rare. They occur in less than 1 in 10,000 individuals and seem to be more of a problem in those individuals who do not have severe osteoporosis and who have been started on treatment for maybe just a low bone density. We therefore have very effective treatments for osteoporosis which have minimal side effects and need to be given long-term to ensure the well-being of our patients. The question arises, can a patient stop their anti-osteoporotic therapies if they have severe osteoporosis? And the answer is no. If a patient has multiple fractures and severe osteoporosis, they will require lifelong treatment. The reason for that is looking at the way the anti-osteoporotic agents work. Firstly, if we ask the question, can anyone stop treatment for a medical condition? And the answer to that is no. If you've had a stroke or if you've had a heart attack, you need anti-hypertensive medication and cholesterol medications for life. The same is the case in severe osteoporosis. The 2 classes of agents that we use are either bisphosphonates, which can be given orally or intravenously, or subcutaneous denosumab. Their actions or modes of actions are completely different. If we start with bisphosphonates, they bind avidly to bone and can stay retained in the hydroxyapatite of bone for many, many years and have a continued action even if not administered regularly. Can a bisphosphonate therefore be ceased because of the long-term retention of the drug? And why would you stop it? The question is, if you give it long-term and you inhibit bone resorption to more than 90% over many, many years, you increase the rare risk of osteonecrosis of the jaw and atypical femoral fractures. And this has led to the discussion of a drug holiday or cessation of therapy. Intravenous bisphosphonates are retained in bone for much longer than oral. And if we look at the data of withdrawal of bisphosphonates, and you look at specifically at BMD and fracture risk, we see the following. Firstly, that there are no really good randomized controlled trials comparing patients who've been treated long-term with bisphosphonates versus those who cease their drug. There are shorter-term studies of 3 to 5 years. And what we note from these studies with bisphosphonates is that with oral bisphosphonates, the BMD may stay high and only return back to baseline after 3 to 5 years, with zolendronate, the intravenous bisphosphonate, much longer, and that the bone turnover markers remain suppressed for a long period of time. Raising the entity, well, is it possible to cease the bisphosphonate? However, when you look at the fracture data, and there's very limited fracture data, we see that from large studies, for example, a recent study database of over 70,000 patients, that the risk of hip fracture increased between, the relative risk of hip fracture increased between 40 to 60% after individuals had ceased their bisphosphonates for more than 3 to 4 years. So it's not a benign entity. If you cease the bisphosphonate for longer than 2 years, your fracture risk seems to go up. If you look at denosumab, that's a completely different drug with a different mechanism of action. It inhibits osteoclast recruitment and osteoclast bone resorption. But within 6 months after ceasing the drug, there's a marked rebound in resorptive activity and an increased fracture risk. So there is really no long-term benefit after administering denosumab for even 10 years. You will see this rapid bone loss occurring 6 to 9 months after cessation of the drug. So denosumab has to be given long-term, and there is no place for a drug holiday. The timing of denosumab is vital for its efficacy. That is, it needs to be strictly given every 6 months. We know that 3 months after that window, that is 9 months from the last dose, that bone turnover rapidly increases and the risk of rebound vertebral fracture increases. The question arises, what do you do when denosumab is discontinued? Has the patient discontinued it because the patient had a side effect to the drug? Or have they discontinued because they're going to see a dentist? Or have they just simply forgotten their medication? As I mentioned earlier, it is vital that the medication is administered 6 monthly, timely and regularly. So what do you offer the patient who has forgotten to take their denosumab injections? So first of all, there is no consensus statement regarding the optimal treatment for patients who have missed their denosumab dosages. However, there are certain very small studies which have shown positive benefits of bisphosphonates in individuals who have ceased denosumab. I must emphasize these are small studies looking at under patient numbers of 20. When denosumab is ceased, if bone turnover resumes to normal or rebounds, then both oral and intravenous bisphosphonates would probably be equipotent and effective in inhibiting bone resorption and reducing fracture risk. However, if the bisphosphonate is going to be given soon after the denosumab has been discontinued, when the bone turnover is very, very low, then there may be a preference for oral bisphosphonates. Let me explain why. Bisphosphonates bind avidly to bone and stay in bone, but their binding is influenced by bone turnover. So if bone turnover is very, very low, they don't bind to bone. And if you're going to give a single intravenous infusion, the chance of that infusion and that medication binding to the hydroxyapatite of bone is limited. Whereas if you're giving an oral bisphosphonate, which you're going to be giving every week for the next 1 or 2 years, the bone is continuously exposed to the bisphosphonate, and therefore the binding of the bisphosphonate will be more efficacious. And so it's probable that oral bisphosphonates are preferable to intravenous in the very early stages after ceasing denosumab. Bearing in mind that she already missed her last dose of bisphosphonates, it would probably be better for her to be on a regimen which is weekly to ensure regular compliance. And she could then commence an oral bisphosphonate on a weekly regimen, which she could take for 1 to 2 years and then reassess her progress and discuss with her after that whether she wishes to recommence a 6-monthly regimen of denosumab or an annual regimen of zoledronic acid, or if she just wishes to continue with a monthly regimen, a monthly or weekly regimen. So adherence or persistence with therapy is vital with any long-term treatment. Otherwise, if you do not take the drug, it does not work. So we have to improve patients' adherence. In my practice, I find that discussing with the patient the implication of osteoporosis, that is, the risk of fractures, the impairment in quality of life, the potential premature death from osteoporosis, because fractures cause premature death, is very important, so that they get an understanding that you are treating a disease and not just a number. Once they've understood that, and you reassure them that the side effect profile is not significant and that there is no long-term side effects, then they become more inclined to taking the therapy. But once they're taking it, we have to try and keep them on the therapy. And by doing that, you have to keep on reminding them how important it is for the drug to be effective, that they have to take it regularly, and remind them about the complications if they don't take the drug. So in my practice, I do that. I use other tools which help the patient understand their disease, such as a bone density, because if they see an improvement in bone density, then they feel that the drug is working. We can use blood tests such as bone markers, which show that they're positive. And those factors help the patient to feel comfortable that they are winning the race against their disease. For the general practitioner, the practitioner has to have that communication with the patient, and the patient has to feel comfortable that they are going to take the medication. But with treatments that are weekly, it is easier to remind patients, and patients don't forget taking their medications. But if you give the medication only once every 6 months or every 12 months, then they often fall off the radar. And so it's important for the patient to have a diary where they mark when their next dose of treatment is. And it's also important for the general practitioner to have some form of software that will have patient recall, so that it really behoves the practitioner to contact the patient and remind them that their next treatment is due. I think we're in new territory. We have Australian guidelines for the management of bisphosphonates and discontinuation of therapy, but we do not have recommended guidelines for the long-term management with denosumab therapy. The guidelines for bisphosphonate therapy is that the treatment of osteoporosis needs to be reevaluated after 3 years of intravenous and 5 years of oral bisphosphonates. If an individual has a high risk of fracture, that is multiple previous fractures and a low BMD, then they will require ongoing and long-term anti-osteoporotic therapies. If an individual has a low risk for osteoporotic fractures, that is, they were commenced on bisphosphonates because of a low BMD, they haven't had recurrent fractures, and their BMD has improved significantly into the osteopenic range, then it may be safe to cease the bisphosphonate, but it is imperative to reevaluate the patient again after 12 to 24 months with repeat BMD, and to have a discussion with the patient that the patient's risk is not zero, that they still have a risk for fractures, but that we are trying to lower the risk of the complications of the medications, and that the patient's risk for ongoing fractures will probably increase again after 1 to 2 years of no therapy. I mentioned there are no definite guidelines for the long-term management of denosumab. The recent evidence is new evidence which shows anecdotal reports of increased rebound vertebral fractures, as well as the post-hoc analysis of the FREEDOM study, where individuals that were treated with denosumab for 3 years and treatment was ceased. In these individuals who had previous multiple vertebral fractures and severe osteoporosis were shown to have significant bone loss and a more than 3-fold increase in recurrent fracture risk. There is therefore presently no role for a drug holiday or cessation of denosumab therapy. If denosumab therapy was to be ceased, then an alternative agent such as an oral or intravenous bisphosphonate would need to be replaced. We are once again facing a negative impact on the treatment of osteoporosis. Many years ago, the entity of osteonecrosis emerged, and it became publicized nationally, and many patients gave up their treatments of osteoporosis for the fear of getting osteonecrosis of the jaw. A few years later, the entity of atypical femoral fractures emerged, and once again people thought that the treatments were causing brittle bones and gave up their treatments. And now we see a third hurdle which will have a significant impact on the management of osteoporosis, and this is the entity of a drug holiday. Without the understanding of the physiology of how the anti-osteoporotic agents work, we are going to see a marked increase in osteoporotic fractures. Many patients are going to give up their treatments thinking that they can stop their anti-osteoporotic agents and that they would be protected by ongoing long-term benefits. This is not true. We need to break the cycle. We need to emphasize the importance of long-term treatment and ensure the patients that they require these treatments, because they're going to do far worse without treatments, having recurrent fractures and a poor quality of life. This will add to the dismal management of osteoporosis which currently exists. We know that less than 20% of individuals who sustain fractures are receiving optimal anti-osteoporotic therapies, let alone the large number of individuals over 70 years of age who have multiple risk factors for osteoporosis. Neither of these are receiving treatments, and now those individuals who were treated are going to give up their treatments. And so we are going to go back to the 60s, where osteoporosis will be ineffectively treated.